Good evening, everyone. Hi, I'm Ken Haynes, and I want to welcome you all to our first virtual summer series hosted by Atrium Health Foundation. Hopefully the weather's going to hold up and we don't have too much noise in the background, but I really appreciate you all being here. As I said, I'm Ken Haynes, the president of the Greater Charlotte region for Atrium Health. And I want to thank you for joining us virtually nonetheless, so that we can all enjoy time with two of our outstanding inspirational thought leaders for the Atrium Health Sanger Heart and Vascular Institute. Some of you may be familiar with Sanger, but for those who are not, Sanger Heart and Vascular Institute has been committed to delivering world-class cardiovascular care for more than 50 years. It was founded by Francis Robicek, and Dr. Robicek was a pioneer in cardiac surgery. And unfortunately, this past year, we lost him. But Sanger's history is one of innovation that lives on in his legacy. During these challenging times, this has become even more important. Sanger physicians are continuing that legacy through an early adoption of the most advanced technology available in the world and the advancement of new treatments. Sanger's nationally and internationally recognized experts are providing patients access to the most comprehensive care, ranging from general cardiology to the highest surgical complexities, including adult and pediatric heart transplant programs. Tonight, you will learn more from these leading experts. At this time, I'd like to introduce Dr. Jeff Rose, president of the Sanger Heart and Vascular Institute. Jeff is an outstanding leader on my team. He is a graduate of the Paramount School of Medicine at the University of Pennsylvania. Dr. Rose completed his fellowship training at Mass General Hospital. He's been a champion of quality improvements initiatives to enhance the patient outcomes and has published extensively about the intersection of quality improvement and his specialty of echocardiography, as well as the entire evolution of our healthcare reform. So without further ado, I introduce Dr. Jeff Rose. Jeff, come forward.
Ken, thanks so much. And to everybody who's able to join in tonight, I wish I could be in person, but it's great to see so many faces here on Zoom. Ken mentioned a lot of the work that's going on in the Sanger Heart and Vascular Institute. And what we thought we would talk about tonight, and I'm going to be joined by Dr. Kevin Lobdell, we wanted to talk a little bit about what's on everybody's mind, and that's COVID. And how we've been thinking about that in Sanger, how we've been thinking about that in Atrium Health, what the future may hold in terms of care, and some of the work that we've been trying to lead here in the region and quite frankly throughout the country. So let me just go through a few slides. Promise not to get into too much technical detail, but nonetheless want to make sure that when we leave tonight that everybody's got a good understanding of this pandemic and how we're responding, how it affects the heart, and how we're thinking about things. So if we could move to the next slide, please. So just to level set, why is it called coronavirus? And this picture that I borrowed from my colleague Tony Asher really tells the story. So on the right, you can see the corona of the sun during an eclipse. And this small virus has a corona, if you will, or a crown of proteins. And it's those proteins which allow it to infect us, to enter the cells. And it's important to have this as an understanding, because as we learn more about the antibodies and the various vaccines that are emerging and so forth, it is the response to those proteins on the outside of the virus as to how those things work. And that's important because it's going to become important as we go forward. Will a vaccine be able to infect me? And the answer is going to be no, because the vaccine is going to be directed to what's outside the virus. The things that make us sick are on the inside. So that's an important thing to understand as we go forward. Next slide, please. So how do we know what's going on? We read so much in the paper, there's so much information, maybe too much information it seems at times. How do we understand what's going on, particularly in our region? We know that this has behaved differently throughout the country, but what's really most relevant to us, our friends, our families, our neighbors, and quite frankly, our healthcare facilities to be able to provide care for people is really how it's behaving here in our region. This is just a curve of some of the analytics that we have. And, it's important for everyone on the call to know that the analytics team here at Atrium is responsible for generating this. While there's data from the state and other sources, these are data from our 11 county region that we're able to put together. And when we think about this virus, the number that we use is what's called the R sub T. And what that means is if somebody has it, how many people will that person go on to infect rather. And you can see by that red arrow in the beginning back in March, based on all the data and all the statistics and how fast this was beginning to spread, that number was very, very high. And we went through the shelter in place efforts that were so hard on everybody, but you see how that curve fell down to less than the red line, which is 1. And that's where we need this to be, because if this behaves at a value less than 1, the pandemic begins to burn out. The blue lines that you see there spiked on the graph are important. The first one is when we went through phase 1 of reentry here in North Carolina, and you can see how things picked up a little bit and settled down. Then we went through phase 2, and things picked up and settled down and kind of smoldered along. And then the last one that you see was actually 4th of July weekend. Now I'm happy to report where you see the blue line above, as of the last 3 days, we're back below the red line. So the behaviors that we're doing, the masking, the social distancing, all of that is absolutely critical, because that's what we need. We need to keep this below that red line so that we can keep things in check, so that we've got the capability to provide care for everybody who needs care. So why don't we go to the next slide, please? So we use this, and I won't go and spend a whole lot of time on this, but these are the types of curves that help us figure out our hospital capacity, the beds that we will have available, and so forth. The red line shows us what the behavior is of the prevalence of COVID in our 11 county region. And then you can see the blue line is how we predict what we're going to need for ICU beds and so forth. And that's critically important, as we'll come to, in terms of our ability to not only care for patients with COVID, but patients who have other urgent medical conditions that aren't related to COVID. So critically important, and we'll come back to that in a little bit. Next slide, please. I'd like to just take a moment to walk you through this slide, just to let you know the types of information that are out there. The red arrow that you see pointing down to the squiggly purple line, that actually represents our activity as gauged from our cell phones, from cell phone towers. So we don't know who's who or what's what, but you can see from that curve that from a higher point back in March, we have all reduced our activities. There's less movement because that movement can be tracked. You see in the blue lines, once again, as we went through reentry, and we've become more active, which is certainly understandable, but you also would see by that black line that the cases are rising. So we know that there's a correlation between the activities that we participate in and how this pandemic behaves, which is why it's absolutely crucial that we're practicing safe policies as much as we can by masking and social distancing and the things we're all familiar with. Next slide, please. So how did we respond? Because this is I would say this is more than a generational challenge. This is something that we have not thankfully, had to encounter previously in terms of how we provide care. Everyone is familiar with the pandemic of 1918, and obviously healthcare systems have not been challenged to that same degree, and now we have been. So this is just an example of what our experience was. The blue line represents how many patients we would see at Sanger Heart and Vascular in a typical week. So almost 4,000 patients. And you can see as March began to progress and the pandemic began to spread, what happened. And all of a sudden we found ourselves where the red line is, and that's where we were really getting into shelter in place type circumstances. What the orange represents are virtual visits. And you can see how in literally 1 week's time, we were able to convert our care for our patients from an in-office, in-person experience to a virtual experience and then be able to grow that. In fact, we were able to convert our visits to over 95% virtual in 2 weeks' time. Next slide, please. And that's important, and I would want everyone participating here tonight to know that the efforts that went on throughout Atrium Health and throughout Sanger to really be able to provide uninterrupted care to our patients through here. We were recognized by U.S. News and World Report, by the Wall Street Journal. Our approach to this was also something that we were able to write up and have accepted by the New England Journal of Medicine, really to talk about how systems of care need to be able to respond and to respond in fluid fashion to circumstances that, quite frankly, nobody woke up in January or February expecting to have to do these things. And at this point, I'd like to turn things over to my colleague, Dr. Kevin Lobdell. Kevin is a cardiac surgeon by training, but is a real thought leader in systems of care, quality of care, and how to provide care at a system level. And quite frankly, a lot of the work that Kevin has led in Atrium and in Sanger over the last decade or so is what led to our preparedness for this, to cope with this pandemic. Something that I mentioned before would be really a circumstance nobody could anticipate. So Kevin, welcome, and let me turn things over to you and have you walk us through some of your thoughts about this pandemic.
Thanks, Jeff. I want to thank you and Ken both and highlight the terrific work that you're doing for this reentry that you've been involved with now for, I think it's a couple of months. It looks fairly simple on the slides, but I know that the work that you guys have been doing behind the scenes to get us reopened, make it safe for our patients, their families, and the staff is incredibly hard work. So again, thank you. And importantly, I want to call out before we get into this, a big thanks to the Duke Endowment. I think Jay Kennedy's on the phone with us, and also Katie Caney, who's been involved in virtual work for quite some time with the system and been a big supporter leading up to the work that we'll talk about here. So first slide. I'm going to tell you a little story. So it's November the 2nd, 2013, which was a Saturday. I just finished playing golf, and I got a call on landline at the club, and it was Elliot Crutchfield, who said, Coach is down in my backyard, can you come over? So I think I set Glen Eagle's speed record for about 3 times the speed limit getting over there. See John and Robin. John was certainly having some problems. We quickly got EMS there, got him to the hospital. I think Jeff met us shortly thereafter. We got John evaluated for his problem, and on Monday, John had surgery. On Thursday, he went home. But what is really important about the story is what we learned from John and Robin in the process. And it was really about some of the challenges and gaps in our care. I distinctly remember as John and Robin were getting prepared to leave, the mountain of information that they were getting. And John, in his usual jocular way, was laughing about it and asking funny questions. But I could see the fear in Robin about being prepared for this transition and how is she going to help, care for John. And then along the way, simple things would come up where they'd contact me and ask about, say, John being lightheaded or something like that, and we realized we didn't have a blood pressure cuff. I remember taking one over to the house. I can also remember questions where if we had audio-visual communication, it would have been helpful. Certainly things like FaceTime, we would do those with our family, but we didn't have the ability to do that with patients at the time. As a result, John and Rob and I spent a lot of time, I would say maybe 90% of the days between the time they left the hospital and when John was back to coaching about a month later, we were there going over these details and again seeing the gaps in care. Next slide. What this slide is to depict is that not everybody in North Carolina has this great network and sense of community that I described with John and Robin. Recently in the Wall Street Journal, there was an article about the increasing challenge with rural, say, North Carolina. In fact, North Carolina has the second largest rural population in the country. And then sometime between that article and today, Wallet Hub talked about best access and best health care, and then rated that in the 50 states. And what's circled, it may be a little bit hard for you to see, is Georgia, South Carolina, and North Carolina are near the bottom. Let me clarify that. What I'm not saying in any way, shape, or form is that our health care organizations aren't good. What I'm saying is it's hard for people to always have access and the quality of care they need, particularly in these remote areas. So if you piece together what I described with John and Robin as a real world example, and then this challenge that we have with disparities and rural care, over the last 10, 12 years, thought a lot about how do we do that. And fortunately, 2 years ago, next slide, we presented this concept to the Duke Endowment, and they were kind enough to believe in us and grant us $1.11 million for a 3-year effort where we would remotely engage, educate, and monitor patients, and then at the same time collect information and share it with other institutions in the form of a learning collaborative. So again, big shout out to the Duke Endowment, incredible gratitude for that. This complements work that we'd been doing along the way. I mentioned Katie earlier in telehealth solutions. We were able to tele around for quite some period of time over the last few years, as well as build a new electronic cardiovascular ICU, which the Matei family was involved with. And this work that I'm now going to describe is just an extension of that network of care that we have. Next slide, please. What we're doing right now is remotely monitoring patients with nurse navigators, and that includes audiovisual, just like Zoom meetings like we're on now, along with a digital health kit. So think about Bluetooth-enabled scales, blood pressure cuffs, and fitness trackers, as well as getting patient-reported outcome measures. And we're aggregating that information, and we're using it in regularly scheduled visits, as well as just checking in remotely with patients to make sure that they're recovering appropriately after surgery. Next slide. We've mapped out exactly what that looks like over a 3-month period after the time of surgery, in addition to engaging them preoperatively. Next slide. One of the things that we found in this process is we at Atrium had the tools to do this, but there were still some challenges with respect to workflow and the work that the nurses or the patients were having to do. And so we've recently partnered with a company to create this scalable, sustainable solution where all the patient has to do is download the app, and then the navigator can work with an iPad or an iPhone or from a desktop computer and manage the patients remotely. Again, they have an audio-visual visit, they can do messaging, they can do scheduling, they can see pictures of wounds and that sort of thing, as well as get the biometric data, the number of steps, how they're sleeping, things like blood pressure, glucose can all be integrated. And then the navigators and our care teams can even see population views to see if we're in check with blood pressure and other metrics that we follow. Next slide, please. So far, we've engaged 171 patients. We have 684 virtual visits. We have 195 interventions. When I say that, things that we think needed to be addressed, and we think we avoided 70 office visits, 28 emergency department visits. And just to give you some more details, that's with 0 deaths in the 171 patients, along with complication rates, readmission rates, length of stay. They're all better than what the benchmarks are. So at the very least, what we've been able to do is create this system to engage the patients and do the work, and certainly not be worse than what we've been historically. But we have a lot of data to suggest that we're actually doing better with respect to length of stay, readmissions, as well as complications that can be associated with surgery. Next slide. What we've had to do with this is have the ability to aggregate data, both novel data and greater volumes of data, make sense of it, and be able to visualize it. And we now have all of that software in place, and these are just sort of screenshots to give you an example of what that looks like. Next slide. We're also in the process of building the collaborative with those in the region, and that's North Carolina, South Carolina, but also now Atrium's in Georgia, working with Navicent. And also we've begun to have talks outside of that region, Virginia, Maryland, Northern New England, to create a greater network where we'll share this data and try to learn from each other. Next slide. Those institutions, as I would have pointed out, are Sanger Heart and Vascular Institute, Navicent, but also Wake Forest, Wake Med, Cone Health, Bay State, which is in Massachusetts, which is very involved in enhanced recovery efforts, Hartford Health, New Hanover, East Carolina, and then the Virginia Collaborative, which has 17 cardiac surgery programs, and the Maryland Collaborative, which has about 10 programs. Next slide. Things that we'll be sharing, I mentioned sharing data, but also scorecards, how we grade ourselves, pathways, protocols, extending the models that quantify risk, and then also, again, working to spread this ecosystem of high-value patient-centered care. Next slide. So the next things that we have to do are go really from pilot to scale or transform our clinical operations. This last year will be very deliberate work like that. It's already been underway. We're heavily engaged, but we have to really work with that timeline in mind. And then at the collaborative level, as I mentioned, expanding the ecosystem so that we can learn and improve faster, aggregating larger volumes of data, and even working with artificial intelligence in the background to help us make sense of this. We've also begun some of the discussions with industry, for example, but we want to extend that to policymakers as well as payers to see if we can share data and also share risk to improve our efforts. Next slide. One more story, and then we'll go back to Jeff. So I recently got a call from one in our greatest generation, 94-year-old, chronic history of atrial fibrillation, but recent flare-up. I think there's another part here. What I was asked was, could we just come in and kind of bypass the system and get an EKG, which historically we've been able to do, but as you know, we can't really do those sorts of things. And so I thought, well, you know what we'll do? We'll use LiveCore. So I bought the LiveCore, sent it, and now can get the EKGs remotely. And I've now done this with other people. Recently, same person returned from Arizona, had considerable leg swelling, said, you know, what can we do? Well, it was fairly easy, right? You send a scale, send a blood pressure cuff, we can monitor those things remotely. And because of the way we sequence this, it may have let the cat out of the bag, but this is my dad that I now help manage remotely. And it's really a touching story, important to me, because it's a body of work that we've worked on for years that now we're able to apply to our own loved ones. So the great work that John and Robin helped point out where there were gaps, the Duke Endowment believing in us, Katie Caney, Ken Haynes, Jeff, you know, supporting us doing this work, we're now able to do this, and it's very touching to be able to help family members that same way. Next slide. Really what I want to do here is just thank everyone for their friendship, the trust, the support, and helping us improve care. It's everything from those like Grant Schoonmaker, who I think is on the call, that's been a part of this and a patient of ours, to Johnny Harris, Mike Malone, Felix Sabatis, Mr. McCall, and then those that we've collaborated with, which Jeff alluded to earlier, like the McChrystal Group, Stan McChrystal, who's a friend, and Chris Fussell, which has led to publications, Bloomberg Radio interviews with David Weston, It's really been great to see the system, the patients, and the team get this great work highlighted. So thank you, and back to Jeff.
Well, Kevin, thank you. Absolutely tremendous work, and I think everyone on the call here today, has heard the phrase "chance favors the prepared mind," and I think that tying this together, the response that we've been able to put together and craft for our patients during this unprecedented time is really founded on the work that has been going on for quite some time, and I think you can all see the depth and detail and thoughtfulness that has gone into really finding new ways to bridge gaps in care. And we live in a great era where we have unprecedented access to technologies. One of the key issues, and Kevin didn't really speak to this maybe as much as he might have, but it has really been our ability to push these technologies to those who don't have ready access to this. And this has really enabled us to really extend care beyond the walls of the hospital. And I think that that's the takeaway that we're seeing from COVID as we're going through this, is how do we find the right combination of care inside the hospital walls, but also outside, in the patient's homes. In the Wall Street Journal article that I referenced, we did the calculations. We calculated when we were doing 500 virtual visits, that was 300 Medicare patients that did not have to come to our office. Now, certainly can, and we will see patients in the office, but if we can provide care in other contexts and other venues, we think we're doing something. And if we can amplify that care by providing remote monitoring that we can track over the internet in a secure fashion, blood pressure cuffs, rhythms, those types of things, we can really make a difference in the care of the patients that we provide. So why don't we go to the next slide, because I want to just talk a little bit more about some of the impacts that COVID has had for us, and then we'll talk a little bit more and answer some of the questions that you've been so kind to send in. So what have we learned? We've learned as a system that we can respond rapidly. We've learned how to stand up some new technologies at scale, which is not a small accomplishment. But we also learned some other things that perhaps we didn't anticipate. In the blue bars on this graph are the average number of patients we will treat in a month for a heart attack. And you can see that there's some variability over the months with time, but it will average somewhere around 130 patients per month across our system. Look what happened in red as we got to the depths of COVID, if you will, when we were in shelter in place and shutting down and so forth. Now, COVID does many things, but COVID does not cure heart attacks. What this tells us is that when we have to respond to emergencies, we begin to impact the care of other non-COVID emergencies. And that's what we saw. We saw these same data for those seeking stroke care. We saw similar anecdotal experience of those coming in with appendicitis and so forth. So the takeaway here is that while we are all learning to manage and live with, this unseen enemy, if you will, we also have to find a way to go about life and take care of the things that we need to take care of, because there are consequences to inaction. And this is what we saw. This is a phenomenon that we've seen across the nation, and it's something that we want to make sure is understood. And you all have a great influence in the conversations that you have and the folks that you speak with, so that we all understand that we're really in a delicate balance of managing COVID and non-COVID alike. If we could go to the next slide. So in terms of what's ahead, when we use those same data that I referred to before and we look at, well, how is this affecting the prevalence in the community? We will have a prevalence in the September-October phase of less than 20%. It is said that to achieve herd immunity, we need to be somewhere around 80%, maybe 60%. But you can see that despite everything that's going on, we're not going to be anywhere near that. we're going to need a vaccine, and so much work is going on in that development. So what do we do in the meantime? And that comes back to the points that we've outlined here in terms of finding new ways to provide care to those who need it and being safe. And the social distancing, the masking, and all of those things are critically important so that we can maintain capacity for what I'll call regular care on a regular basis. If we go to the next slide, as we even think further down the road, what does 2021 look like? And that's anybody's guess in terms of things. I put this slide together, though, because I wanted all on the call to know about one of our recent recruits here to the Sanger Heart and Vascular Institute. Dr. Dermot Phelan joined us from the Cleveland Clinic last year, and Dr. Phelan is an expert in this emerging field of sports cardiology in the sense of the particular cardiovascular considerations and concerns of elite athletes, of first responders. Dr. Phelan does work with the NFL Combine, with the NBA, with USA Cycling and USA Swimming. This is just a piece that was picked up by USA Today as he was presenting his views on how to be COVID safe as we're looking forward, down the road towards the Olympics. So we've really worked very hard, here at Atrium and at Sanger to bring literally world's experts together to be thinking about, how to provide the best cardiovascular care for our community. And if we go to what I think is our last slide here, so where do we go from here? And this is a rendering, and if you've had the opportunity to drive towards Uptown on Kenilworth, you'll see that we're moving very quickly on the construction of this building, which should be open and by the second quarter of next year. And this is going to be the new home for the Sanger Heart and Vascular Institute. We will certainly continue to have a strong presence within our hospital-based facilities, but this particular facility is going to be our home base, if you will, from cardiac rehab to community education to the clinical care with all of the imaging and all of the things that our patients need in one place, plus an opportunity for all of our cardiovascular research teams to congregate our center, our Gross Family Center for Cardiovascular Care Transformation. And a lot of the work that you've heard about tonight, this is going to be the hub, and we're incredibly excited and just so privileged to have that opportunity. And we look forward to that next year and look forward in the future to having events like this in person in such a facility as you see there on the screen. So, with that, those are the prepared remarks that Dr. Labdell and I had for you all tonight. I know that there were some questions, and I think Kirsten is going to read those out, and perhaps we'll put Kevin on the screen as well, and we'll do our best to answer the questions that you have. And I would also invite you to participate as well. For those who are able to participate online or text in, we would certainly love to take this opportunity tonight to answer any questions you have about COVID, about how Sanger is thinking about that, or other aspects of cardiovascular care and how Atrium is responding to the care needs of all in our community. Kirsten?
Thank you, Dr. Rose. Good evening, everyone. This is Kirsten Ashford with Atrium Health Foundation, and we just want to thank all of you, our great physicians and all of our guests tonight for joining us. And I will start off with 4 questions that we have that were submitted in advance. The first one is about transmission. There's a lot of discussion of cleaning surfaces. Do we have an idea of whether transmission is primarily through the air, and is that aerosolized or droplets? Or are people also getting infected from surfaces?
So that's a great question. Our understanding is that this is principally through aerosolized droplets that we pick up, and we get it on our hands, and then we touch our face or our eyes and so forth. And that seems to be the primary mode of transmission. Yes, it's possible that it can be on surfaces and then people can touch those surfaces. So things like doorknobs and computer keyboards and all of that around your home, certainly. Here at in our facilities, we're absolutely vigilant about cleaning all those common surfaces because of that possibility. We find that frequent hand washing, using the sanitizers, or soap and water, and singing the birthday song so you're doing it for the appropriate amount of time, not touching one's face. Those things are critically important. And then for those of us providing care, you'll notice now that when we're in the care environments, we're wearing face shields more than just glasses. Sometimes those are plastic shields, but just the plastic goggles will work. It's all hands on deck, but principally this seems to be around the droplets. Now, the virus droplets are very small. The surgical masks and the cloth masks will contain not all of those droplets, but a significant amount, and it's critically important to understand that. If I could share just a couple of quick pieces of data here. So Hong Kong, very, very densely populated space, 7.5 million people. They've had fewer than 10 people pass from COVID. Mask wearing is 97%. Japan, fewer than 1,000 who have passed from COVID. Mask wearing, incredibly high. It's the tool we've got in the toolbox, and anything we can do to not politicize this, but socialize this from a medicine standpoint is going to serve us all well in our communities, but also, again, continue to provide access on the care side for the non-COVID care that is equally important.
Okay.
Kirsten?
Thank you. Next question. Sports. Our daughter is on a club lacrosse team that has been practicing outdoors and has a few games on the schedule in the coming weeks. We understand that outdoors is better than indoors. We also hear that kids are not catching COVID-19 as easily. How should we be thinking about the risks associated with this?
Kevin?
Well, first off, I would say I'm not an expert in all the details associated with that, but outside certainly better than inside because of airflow, that sort of thing. Back to the question of droplets, aerosolization, touch, I think that if the kids are playing lacrosse, not sure that they're wearing a cloth mask underneath their helmet and face mask, but I would recommend, for instance, if it was my daughter, that they did that. I think with their gloves and the stick, the chances of contact transmission would be extraordinarily low. I think the greatest risk in that is probably around the time of games and practices where the kids are interacting, as opposed to actually when they're playing or throwing the ball in practice, that sort of thing. And maybe to answer it in a different way, whether it's soccer or lacrosse, if we know people are going through the proper screening before they're out there to make sure they're not symptomatic and that they are wearing a mask while they're practicing or playing, I would let my son or daughter do that. I hope that is a good explanation and reassuring. Jeff, if I've forgotten anything, please add, because there's real potential.
No, that was very comprehensive, and I share your opinion as well. I mean, I think the critical piece is not letting one's guard down. I think that there's less risk and issue running around in the open fields and so forth. I've got son who's a soccer player, but it's really the issues when the teams come together and the protection that's there. So that becomes critically important, and kids get it. And kids can transmit it. So I think that that's also something that we need to know. So Kirsten, next question.
Sure. What are the 5 most important things you can do for heart health, brain health, and longevity?
Okay, so that would be exercise, 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 and eat right. Now, all kidding aside, the absolute importance of being active as we go forward in terms of keeping our brains healthy and our hearts healthy. I can't stress that enough as to how important that is. Yes, it needs to be coupled with, a diet that is sensible, absence of smoking, and other. We know the things that we should not be doing, but I don't think we perhaps maybe amplify as much the things that we ought to be. And very, very specifically, if we could get everybody walking, just a brisk walk, 30 minutes a day, 5 days a week, we would drop cardiovascular mortality in this country more so than we have with stents and statins. So just the impact of these simple things, but as Warren Buffett would tell us, it's simple, but it's not easy. And it becomes critically important to find ways to integrate that into our daily routines. And it becomes even harder, as it's, very hot outside and can't go to the gym because of the things that are going on today. So we have to find other ways to do this. But can't overemphasize enough the importance of a regular disciplined exercise program. We're not talking Olympic level, we're talking a brisk walk. And if we can do those things reliably, 30 minutes, 5 days a week, that's 150 minutes a week, eat a sensible diet, and pay attention to other aspects of our general care, we can have a tremendous impact and really have healthy lives.
Yep.
Okay, next question. We know that a person can spread particles by talking, sneezing, etc. And if they hit a surface and we touch that surface, then touch our face, we can get the virus. Why then can we eat something from a restaurant like a cold salad? What if a worker has the virus and sneezes on the salad? Wouldn't we get the virus when we eat the salad?
Well, I'm going to ask Dr. Lobdell, who's our expert from his last answers, to begin to take that question on, and I'll add as appropriate.
Thanks. And a disclaimer here for those that don't know, my educational background is microbiology, so I have a love for systems and improvement and so forth, and it's been fascinating for me to think deeply about virology, epidemiology, that sort of thing. So I think that the question is a good question, and the answer is there's no fail-safe method. There's just mitigation strategies, and that's everything from wearing the mask to washing hands, even simple things, and it's not answering the salad question, but I'm getting there. If you're ordering things from Amazon or having things delivered to the house, it's everything from letting it sit for, say, 2-3 days if you don't have to use it and touch it, to cleaning things when they come into the house. We've made a real routine of doing that. And then certainly, and I'm not exactly sure how one does this, but I think people probably know, those places that tend to be cleaner and those places that would tend to be more suspect, I would certainly be erring on the side of those things that are predictable, that you have confidence in, as opposed to, I think there was an article today in the Wall Street Journal about quote unquote dive bars. I think we have to be careful about those places that we may have loved but tend to be crowded or have circumstances where it's harder to be equally meticulous. Anything to add to that, Jeff?
No, I mean, I think that that's great advice, and particularly around this unknown amount of transmission that comes from touching, boxes and things of that nature, and and certainly, one would hope that all food is prepared, with the right degree of health concerns in mind, but again, I think we have to all adjust and accommodate to, to new realities. And, we're getting more things coming to our house than we ever had through, through the mail and through FedEx, and the boxes build up and 2 or 3 days later they get opened. That's how things have happened in my house, like Dr. Lobdell's, and I'm sure many of yours as well.
Jeff, maybe one other thing that we can add to that too is I described to Dr. Rose a recent flight for family vacation, and to my surprise, our hub here in Charlotte, and that prominent airline apparently doesn't enforce all the rules about wearing masks. I saw a pilot that was, being transported to another area, didn't have a mask on. A person by me had a shield but not a mask, and probably like many of you in some of these questions, it can create a bit of anxiety. And what I realized in that is, once again, we're our own first responders. We have to look after ourselves, our families, that sort of thing, because there are these real risks out there. So whatever we can do to control that, it helps to reduce or mitigate those risks. And don't be shy about, taking those measures. Control the things that you personally can and those things your family can do.
Yeah, maybe just a good segue as well that Gene Woods and so many others in the community are leading the 2 million mask campaign, right? And making sure that we've got enough access for something we take for granted, a cloth mask, that it's available within our communities for everybody, because that's, at the end of the day, we're all in this together, and we've got to keep each other safe. Kirsten, did I hear there was another question?
Yes, we just got another question in. When should we shift from a primary care physician to care by a cardiologist?
So that's a tough question. So from the simple answer is it depends. It depends on what the particular issue is that you're experiencing in terms of symptoms or in terms of just general cardiovascular evaluation. Do you have a family history of any cardiovascular disorders that might be prevalent and require special attention? Are you finding in your relationship with your primary care physician that the things that are important to you in terms of your cardiovascular health and the questions that you have are being answered to the degree that they need to be to meet your satisfaction? We talk about this boundary all the time between primary care and cardiology, and it's a very fluid boundary. I liken it to that boundary between the fresh water of the river and the salt water of the bay. And somewhere there's a salt line that mixes, and it mixes at a different place for different patients for different reasons. So there isn't a one simple answer there, but I would really go back to really address that at the end of the day, we as healthcare providers are there to meet your particular care needs, and every patient is different. So there isn't going to be a simple script around this. And I would say that if you're finding that the needs that you have or your family are not being, fully addressed in a primary care setting, then certainly from a cardiovascular standpoint, that's an opportunity. But this also leads to, another area of where we're extending care, and another, aspect of care that we were able to put into place in the time of COVID, if you will. And again, this is a program that we had actually started setting up last year, but we were able to flip the switch and get it going. And these are virtual consults. So we talk about virtual visits for you or family to meet with us, basically instead of a face-to-face office visit, but to do that over an iPad or something. But the other channel that we've created with our urgent cares, with our emergency departments, and with our primary care physicians is the ability for us to do curbside consults or even virtual consults with them. So they've got an EKG they're not really sure about, but they just want another opinion. Well, that doesn't mean you have to come see me 3 weeks later while you're worried about that EKG. Why can't we just answer that in near real time, by the end of the day or by the next day, and get that information back and narrow that time of uncertainty and get patients what they need? And that's a real opportunity for us, and as a healthcare system and as a cardiovascular institute, that's a bridge that we've built. So I really appreciate that question. I wish I had a simpler answer for it, but I think at the end of the day it really comes down to collaboration. Kevin, what do you think in the collaboration front? You've thought a lot about this as a network thinker.
It's a great question, and I'm glad that you brought up that last point, because I know you've been thinking about that and doing some work. But I think what Ken and you and Katie and others that are involved in this work would like to see is that we have the systems and processes in place to answer those questions so that the patient doesn't ever feel like it's a dilemma. So ideally, what we'd have if somebody was seeing their primary care physician, internist, family practice person, and there's a question, as you mentioned, about something that needs addressing from somebody with greater expertise, in this case cardiology, that in an on-demand, real-time sort of way you could deal with it if that was appropriate, but also in dysynchronous sort of situations where it's not pressing but gets addressed appropriately, not requiring a patient to make yet another appointment or drive. And so I think that what you've mentioned, we've acknowledged, is we're putting all of the pieces together in the way of people and processes, technologic infrastructure, and so forth to do this work, and it will just continue to expand so that when we look back in 5 years, hopefully people realize we're already doing those things and it's not a question any longer.
Yeah, I mean, I think the first step is, we have to have the expertise, we have to have the facilities, and, coming back to where, Ken began, we lost Dr. Robacek earlier this spring, and, that was always his vision, was to build an institute that had no boundaries between the surgeons and the cardiologists and the pediatric cardiologists, that one team where there was free exchange of information and deep expertise. And that was his life's work in building Sanger, what was then Sanger Clinic, to the Sanger Heart and Vascular Institute. And we're working very hard to carry that on and making sure that we're able to attract the best to come to our region, to come here to the Charlotte area and, put their stake in the ground and become part of our organization. And now we're working to network that expertise, not just within Sanger Heart and Vascular Institute, but across Atrium Health, and to be able to be more accessible to patients and to meet them where the patients need to be. And across the continuum, from primary prevention, we talked about exercise, to the most involved technical aspects of care. That's the vision, and we're just so glad that you're on the call with us tonight and hearing about it and having a better understanding of not only where we are, but where we intend to be.
Hey, Jeff, let me reinforce to your point there, too, that much like we've acknowledged, whether it's in clinical care or the piece that we wrote for the New England Journal, that we live in a networked world. And COVID spread in part because of network, right? The ability to move from China to Europe to here because of air transport and that sort of thing. And the only way we're going to be able to combat network challenges, of which there are going to be more and more at more rapid rates in the future, are with a great network. And as you mentioned, that's Sanger, that's Atrium, but it's even outside. And we're seeing, Gene and Ken involved in various things, whether it's regionally, nationally, or internationally, to have those relationships and build this expanded network. And I think that that's something that underneath all the things that we're saying is we're going to work to optimize, and that is the rate at which information flows, that we can make decisions and execute on plans. And so it sort of ties together the COVID threat that we're facing, as well as the infrastructure that we've put in place, and then the real world care, and then even answers to some of these questions. It's all related to this network that we're faced with.
Well put.
And I think we have another question in from Ken Haynes. Our healthcare heroes have done amazing virtual care during this crisis. What was the cardiovascular growth before COVID?
So, prior to COVID, the number of visits that we were doing in the virtual space was was small. We had a program that we had crafted around advanced heart failure care that continues to this day, so that those who have really special needs don't have to drive all the way to Charlotte to see the experts. So we were really able to build off of that foundation, and then of course what we heard from Dr. Lobdell with respect to perfect care and our ability to connect with our patients during their postoperative period, the time where they're most vulnerable. So we had really just scratched the surface of this, but as I mentioned, we're really ready to go when this happened because of the work that had been laid as a foundation, and work that we were ready to begin on independent of COVID. That Ken and Katie Caney and others were very supportive of, because again, all care should not have to be dictated between the bricks and mortar of the clinic or the hospital. We have to find ways that can meet patients where they are, so we can better extend their health and wellness. So we've seen tremendous growth because of COVID, and we fully intend to keep this as part of what we're doing. It's not an either or, it's an and. And as we go forward, one of the analogies we use all the time is banking. There was a time when the only way you could do a transaction was, with the teller. And now we don't even think about, ATMs and online banking. We just think of it as banking. It's just a different way to get what we need to get those services at high value. And that's what we're, wanting to do, I think, not just in Sanger, not just in Atrium, but I think that this is a need nationally in terms of how we're going to best care for everyone going forward.
And we have another question. When do you think flying will be safe again?
Well, I think, first of all, I think it is actually safe to fly today with proper precautions. So I think masking and I would also recommend goggles or eye protection. I don't know that you necessarily need a face shield. So I think if you have to travel because you need to get to family and so forth, I think it is safe to do so. But by the same token, I think we're all being prudent and not, traveling to the same degree by any means that we were doing before all this started. I think if maybe what I'm picking up on in the question is, when will things be normal? And that's the biggest question I think the world is facing right now. When do we get back to, some semblance of the way things were before in terms of, packed airlines and movie theaters and all. And quite frankly, I think that's not until we have an effective vaccine that we're able to, to treat. I think until that time, we're really dealing with some degree of social distancing and then all the safe behaviors that we've talked about tonight.
Jeff, can I add to that
Please.
too, having recently flown? It's not just being in the plane and having the proper PPE, but one of the things that I found, quite frankly, was one, it was hard to social distance in the airport itself. So if somebody's contemplating, should I do this, and that creates anxiety for them, be aware that that can be a bit of a challenge. Number two, and I'm just being frank, I saw probably 5% of people that weren't wearing a mask at all at the airport, and another 5% at least that weren't wearing them properly. And the reason I bring that up is, as Jeff says, it can be safe, but you have to, beyond just knowing if it's safe, can you do it? Also ask yourself, is that a situation you want to be in? Flying can be something that creates a fair amount of anxiety for people. We've all witnessed that. And if that's the sort of thing that you say, well, I'm worried about my safety and it makes me anxious, I promise you when you go there and you see people that aren't social distancing, not wearing masks, it's going to be amplified in this environment. So please think of that in a very three-dimensional way as you would think about the problem.
Thank you. And I think we want to be mindful of your time. Again, so grateful you're spending time with us this evening. We probably have time for one more question. If there's anyone else who has a question, you can raise your hand virtually, or I can see you on the screen. Okay, it doesn't look like we have any more questions. So at this time, I'd like
we had a
to
lot of great questions.
toss things over to Armando Chartier, the president of Atrium Health Foundation.
Good evening, everybody. I'm Armando Chartier, president of the Atrium Health Foundation. First and foremost, I want to thank all of you for participating virtually in our first seminar that we've done, and trying to remain socially distant and safe. We hope to do many more of these as we move forward. I think it's a wonderful way to communicate with our friends about what's happening at Atrium Health. I want to secondly thank Dr. Rose and Dr. Lobdell for shedding more light on the great plans and advancement of the Sanger Heart and Vascular Institute. As you know, many of these plans, many of these things that were talked about today were supported by great philanthropic partners. So we hope to continue on that trend as we move forward. And just finally, just to take away from all this is that Atrium Health now more than ever is really focusing on our mission for all. We're doing so much in our communities to reach out to folks that really need our help. And if ever our For All mission resonates, it is now. That's my dog barking in the background. So please know that you can reach out to me if you have any other questions. We'd love to get your feedback about what worked about this virtual seminar, what did not work. We'll hopefully try to reach out to you to do that. And again, we hope to do more of these as we move forward. And thank you again for your participation tonight. Have a great evening.